Good afternoon. My name is Scott West. I want to thank the Tennessee Suicide Prevention Network and Marianne Christian for organizing this so we'd have a chance to talk about transcranial magnetic stimulation and I hope that we'll be able to share some information about TMS. And we'll talk a little bit about depression because that's kind of what generates the TMS and also is the large part behind most of the suicides, as y'all well know. Depression affects millions of people, over 60 million, and about a quarter of those people have what we call treatment-resistant depression. That's the leading cause of disability in the world. We have a suicide problem that is building and building, and probably going to get worse in the near future. The residual traumatic events of the pandemic we've been dealing with is going to probably exacerbate anxiety and depression. It'll raise the rate of suicide, I fear. And there are many options available. TMS is one of them. There are the traditional medication options. There are the traditional psychotherapeutic options. So this is one of the things that we now have in TMS to address this. This is a very personal issue for me. It is timely for me to, in dealing with, in having this talk, because it was only yesterday that the person who told me about this, about TMS, took her life 12 years ago yesterday. That was 5 months before the TMS clearance by the FDA to treat depression that hadn't responded to medications. She had been a patient of mine since the early 90s, and in the mid-90s, she was hospitalized at McLean Hospital. And when she came back to Nashville, she told me about some of the research that was being done there on TMS with Dr. Pascal Leone. It finally had its FDA clearance in 2008, and it was a leap of faith as we looked at this as an option to help people, because not everybody was being helped in the same way we wanted them to be, with the gold standard being remission from their depressive symptoms, return to functioning. Depression's a very common emotion, but not everybody has clinical depression. That inability to function, to have pleasure, and limiting life activities is just something that can be overwhelming. And when medications and therapy are not working, we look for those options. Once we started it in 2010, it was October, so it was a little over 10 years ago. April in 2010, it was a little over 10 years ago. We found that people were getting better. One of our early patients came back after her the treatment and said that she felt joy again for the first time in years, since in over 20 years, and that's a pretty powerful thing. There was good research doing TMS, and now there's even better research. We have randomized controlled studies about the benefit. With significant improvement in depression and anxiety, and good remission rates, well tolerated. But now we come out and we have what's called an outcome study. We have a study that's looking at over 8,000 people that have had treatment, and 4,000 of them meet the criteria for us to look at with the FDA cleared protocol. And we have an over 70% response rate and a over 40% remission rate. And these are people that have treatment-resistant depression, meaning they haven't responded to multiple antidepressants in the course of their time of being depressed. This will be published sometime this year in the near future. And so we'll have a chance to talk about more specifics of that particular study. The early experiences that we had with TMS, we added it to the regimens that we're doing, and found that so many people did improve. We also found, and with subsequent studies, that TMS seems to have a positive effect on suicide specifically, decreasing the ideation in the general studies that are done. And then there have been a couple of different studies, one specifically Mark George did at VA hospitals, that had multiple courses of TMS per day for several days, showing significant improvement in acute suicidality. To think of in the sense of depression treatment, but also as we're talking about helping with suicidal ideation and the difficulties that that brings for the individual that doesn't survive, that does survive, and their families. Let's talk a little bit about TMS and what it's doing, because it is a specific type of treatment that uses an MRI magnet that creates a focused electromagnetic pulse. And that focused pulse, as you can see in this particular slide, stimulates the left prefrontal cortex, which stimulates the deeper structures in the brain. And that's in the area called the limbic system that's involved with mood regulation. And it helps with activating the brain. It not only increases the flow of neurotransmitters, but it also increases the metabolic activity in the brain and something called plasticity, which is the ability of the brain to make new connections. We used to think the brain could not do that, but it does. And this facilitates that and enhances that activity so that the areas of the brain are connected better, and thus it helps when we have new stimuli that comes in that might make us depressed in whatever that means, whether that's dysphoric, despondent, irritable, agitated, and the parts of the brain that address coping are communicating better, resulting in a better outcome. And I'll give you some details of that a little bit later. By increasing the neurotransmitters, increasing the plasticity, we get a more normative emotional response at a neural connection. And it even acts at a very specific neuron to neuron status, so that the neurons themselves are interacting better, responding better to the neurotransmitter functioning. You can see in this particular slide, which is a PET scan, in the depressed brain, which you can see on the right, there's not as much activity. The brighter, lighter yellow colors, green, are improved, are more active functioning in those areas of the brain that have to do with blood flow, oxygen use, glucose metabolism. And when people are depressed, all of that's more flat. When people are less depressed and get more activity, that's what happens when people are treated with TMS. And we do the PET scans. We don't do that routinely, but it is a way of at least looking at it. One of the things that we find with TMS is it is a very focused treatment. It's not systemic, so it doesn't have the type of symptoms we sometimes see with antidepressant use. So it has limited adverse effects. There can be scalp discomfort that's typically transient. When the electromagnetic energy goes through the scalp, it stimulates the nerve fibers in the scalp and we feel it. That gets better over time, and people get kind of numb to that. So we don't have to deal with that on an ongoing basis. So this is the TrackStar system, the NeuroStar system that we use. It's all connected. So let me go through the process of a treatment. When somebody comes in, has an evaluation, they have clinical depression, we talk about different options, psychotherapy changes, medication changes, even consider other things such as ketamine, S-ketamine, vagal nerve stimulation, ECT, and help people understand the pros and cons of different treatment modalities. When people decide they want to pursue the TMS and they meet the criteria, oftentimes people use their insurance. Now, most of the insurance companies do cover TMS. They have different requirements, some as much as, or as few as one antidepressant, others as much as antidepressants, including augmentation treatments, plus psychotherapy. So we have to sometimes get prior authorizations. We do that with the patient, and if they move forward, the next step is to have the initial treatment, at which time we find the location and the amount of energy that's going to be used. The coil you can see in the middle of the screen up here is the magnet itself. As you can see, it's connected to a capacitor, and that's connected to a computer system. We have a track star system, so we can load it all together, which makes it a very efficient system to use. People recline in this chair, and the first thing we do is to find the location by finding the area of the brain that prompts the opposite hand to move, specifically the thumb and thenar eminence of the hand. And when we find that location, then we find the amount of energy used by virtue of an algorithm in the computer that goes up and down, and we can see how we don't need to do too much energy, so we find the least amount of energy that's required. All of that's stored in the computer. So after that, we have the first treatment. The protocol calls for 3,000 pulses each treatment, which with this system takes 18 minutes. But we want them to be engaged. Somebody is with them at all times. And we encourage them to be active even when they're not in treatment, to increase their physical activity, to increase their cognitive functioning, trying to find things they can enjoy, they can find pleasure in. That process of each treatment 5 days a week for 6 weeks goes on. Most people start feeling better, about treatment 20, 25, somewhere in that range. There are some late responders. We've seen people not feel better at the end of treatment, and within a couple of weeks afterwards, they're starting to feel better. So we've seen that phenomenon happen in the past. And we also encourage people to continue their current medications, to continue their medications unless there's a specific adverse effect. We want to change the medicines if necessary after we let the TMS do what it does. And fortunately, the great majority of people improve. We find that they cope better. People are better psychotherapy patients after TMS. That was a serendipitous finding that we had, and there's now a clinical TMS society. There are almost 600 of us from around the world. When we started, there were 120 systems in play. Now there are over a couple of thousand, I think, around the world. But we do have an organization that looks at a number of things, which is the best way to treat, ways to improve our response rate, ways to look at other treatment opportunities for TMS. And what we have found is that using this, people not only get better, but they stay better. And we found that by keeping the medicines the same until the treatment is over, then we can try to taper off of medicines if that seems to be clinically appropriate. Some people are able to get off of medicines, not everybody. Some people are able to reduce medicines, and we found that to be the case with most everybody that we treat if they're on a bunch of different medicines. The coping aspect of things is something we've all found happens, and people are better able to cope with their psychotherapy, to problem solve, to develop goals, and to deal with the interpersonal relationships because their mood's better. We had a number of things just to share with you in terms of the types of responses that we have, the anecdotes. I remember vividly a young man in his 40s who was sitting on the sofa that's in my office. His wife was with him, and before treatment, she made the comment, he used to be happy. He had quit his job some months ago because he just couldn't function. He started work again the day after his last treatment. And when his wife met with me and with him a week or so after the treatment, she said he's happy again, and went on to talk about a picnic they went on with the family and so forth. Sometimes it's trivial stuff, sometimes it's very significant things. But one lady told us that her cat didn't come in one night. And she made the comment that before I had TMS, I'd have been worried all night long. Now I knew the cat was going to come in the morning, and they did. Had people that have had their house burned down. and make comments that if they hadn't had the TMS, they don't know how they would have coped with it. We've had more tragic things where people have lost loved ones and have come back and spontaneously made similar comments about how they feel their life is better as a result of TMS. And it's not just the depression. There seems to be something different. And I think it has to do with the plasticity um, of the brain developing better ways of connecting with itself. But TMS, I think, has developed a niche for treating patients that are depressed, that aren't responding. We know that from our own experience, when people have come in and they've not had any medicine, some people just don't happen to like medicines and they've wanted treatment even though they have never been on a medicine. And as long as they know it's off label, we can do that. And people seem to have even a better response. So I think that it does have a significant role earlier rather than later. We're restricted to the later right now, typically because of the insurance requirements. But that's improving. There are more, for example, 3 of the Medicare jurisdictions currently require only 1 antidepressant when they used to require 4. So they're moving in that direction. Cigna and Aetna also have reduced to their requirements from 4 to 2 medicines fairly recently. So it's becoming more, people are more aware of it, and it's something that I'm glad to have the opportunity to share with you. So I'm going to stop now, and then we're going to open up the chat box and see what questions there might be. One of the common questions people ask is, how long does it last? And we don't know for sure because there's not been a definitive long-term study, but there is the longest study for depression that there has ever been, looking at a particular treatment for a year out. And in that study, at 6 months, 11% of people needed retreatment. At a year, 32% of people needed retreatment. At the one at a year, 85% of people that had retreatment demonstrated a return to their previous benefit with TMS. We've been doing it over 10 years now, treated 600 plus patients. About 20% of people have come back over time for some degree of retreatment. One question we've got is it good for bipolar disorder? Yes, it is. We don't have the study done yet. We have treated bipolar depression with very positive response. There will be a bipolar depression study. We anticipate being one of the sites that's going to be participating in that. It was due to start the end of this year, but because of the COVID pandemic, a lot of things got put on hold, and that study got put on hold. I don't know when it's going to start, but it's something that I anticipate will happen end of the year, first of next year, and we'll be looking at making that available. Another question, any health issues that should be considered, any age restrictions? The FDA clearance is technically for ages 21 to I think it's 72. People in the original study were 18 years old and above, we've treated people in their 90s, we've treated people in their teens, so there are no age restrictions. Health restrictions, the only absolute restriction is if you have metal in your head, which typically is an aneurysm clip or coil. That's not very common, but that's the only issue from that standpoint. What's the criteria for a potential candidate? The criteria is someone who has major depression, has not responded to previous treatment, is the FDA criteria. Who invented the device and when? A guy named Tony Barker, who is a neurophysiologist in Wales, British Isles, is the one that actually made the first device. It uses a physics principle called Faraday's law, but Tony was the one who actually created it. And then he was in London and met a guy named Mark George, who's a psychiatrist and interested in brain imaging. He was doing a fellowship in London, and they crossed paths. And as a result of that meeting, Mark brought the concept back to National Institute of Mental Health and is kind of responsible for starting most of the studies about it. The company that then developed it was Neuronetics, and a guy named Stan Miller, who I'm proud to be associated with, was the engineer that kind of shepherded it into the reality of FDA clearance. Mark Dimitrek was the medical director of that company, and that Stan and Bruce Shook started. And that's what kind of propelled it. Once it got the FDA clearance, that kind of let it be something that could be used. I had made the assumption that it would be a kind of academic center type of thing, but it turns out it's an outpatient procedure without anesthesia, sedation, and it's something that can be done on an outpatient basis, which is why we're able to do it. Would this work for PTSD as well? Possibly. TMS is going to work for a lot of things. It depends on where we're stimulating the brain, what part of the brain, and the parameters of that. We know, just like I know that it works with bipolar depression, I know it works with post-traumatic stress disorder, but the study has yet to be completed. That's also on the books for a possible study to be done that we hope to be involved with. Does the VA allow this therapy? Then it goes on to ask about PTSD and TBI efficacy. Again, the efficacy, we know it has some clinical benefit in those clinical arenas. Studies are yet to be done. The 40 of the VAs, the last I knew, it might be more now, have access to this type of system. And there has been one VA study looking at it, at least with depression, and they've been doing some PTSD work as well. One of the studies I mentioned earlier that Mark George did with suicide and people that were acutely suicidal, going into the hospital and having 3 treatments a day for 3 days, those were done in the VA system. How many facilities have it? Locally, there are about half a dozen of us, I think, in the Middle Tennessee area. There are couple in Memphis, couple in Knoxville. ETSU had one. I don't know about it now. And down in Chattanooga, there is a system, as I recall. Around the world, there are about 2,000 or so. There are now 7 different manufacturers of systems. Some have more research associated with others than others do. But it has become more of an international phenomenon. Japan has a lot of activity with this, and their health system, I think it was last year, just approved it. Will insurance cover this form of treatment? 95% of insurances do cover it. That covers over 3 million people. I'm sorry, 300 million people. And the criteria vary from insurance company to insurance company. So the FDA criteria of 1 failed antidepressant and major depression, it might be more strict as it is with most of the insurance companies. We keep hassling them about that. Co-occurring disorders, does it have an effect in helping? It does. There are multiple ways of thinking about co-occurring disorders. Sometimes that can be anxiety and depression, sometimes PTSD and depression. Sometimes it has to do with substance abuse issues. And with substance abuse, it does tend to facilitate improvement in that area as mood can be improved. There are some independent studies that have looked at it specifically for various substance abuse. There seems to be some positive results with that, but not FDA cleared, no big randomized controlled studies. Any side effects? The side effect is the discomfort at the site of the stimulation. There is a very low risk of seizure activity, less than 0.1%. Anytime we stimulate the brain, there's that risk of that photophobic lights or traumatic blows to the head. Seizures can happen. It doesn't cause a seizure disorder. And the discomfort at the site of the stimulation typically is very well tolerated. A few people will tell me that they can have some headaches afterwards, but that's not a common thing in my experience. How similar or different is this to ECT? It is very different. There is one similarity. They both stimulate the brain, and essentially they get to a certain part of the brain. ECT is a large stimulation of the entire brain that that causes a seizure, that can cause confusion. It's been around for 70 years. It has the anesthesia, sedation associated with it. TMS is an outpatient procedure, no anesthesia, no sedation. It is a very focal stimulation of a specific part of the brain that ends up activating the area of the brain we're specifically looking for instead of a generalized approach to stimulating it. So there are those differences. It is, in a sense, a kinder, gentler way of accomplishing the goal of improving depression. Where can someone on TennCare get in? East Tennessee. I think I'm not positive about that. TennCare has been late to the party in terms of appealing it. 9 years ago, Mark Dimitrek from Neuronetics, the medical director, and I had a meeting with TennCare, and they seemed to be positively impressed with it and the potential for it, but for various reasons they didn't cover it. They apparently do cover it now, but they have a very limited group of people that there are in their network. My own experience locally is that Vanderbilt is in that network. They do have a system. They don't use it a whole lot, but they do. Does it help with OCD and depression combined? It does. Helps with both of those. There is a specific protocol that has been FDA cleared to treat OCD. There's some specific parameters around that, and so it's not readily available, but it does tend to help with obsessive compulsive symptomatology and with depression. And person's asking about ECT and TMS as far as the procedure and results. There's been no head-to-head study of TMS and ECT using the protocols. Our experience with TMS is that in this large study of 4,000 people, is that there's over a 70% response rate. ECT over the years has historically had a 60 to 70% response rate. Some studies will report as high as 80%. With ECT, about 50% of people will have a return of symptoms at 6 months. And thus we have a lot of people have maintenance ECT. With TMS, at 6 months, 11% of people had return of symptoms, and in that particular study, 90+% of people responded to a course of TMS again. How does TMS work for depressed patients with PTSD? Basically the same way it does for depressed people that don't have PTSD. Though with PTSD, my experience is that people do have fewer nightmares and flashbacks, some specific PTSD symptoms that probably are a result of the neural circuits and the limbic system having an improved level of functioning. The average number of sessions per client and how much time needs to pass between each session, who can do the sessions and the type of training they need to do them. The average number of sessions is, in our experience, about 30. Some people do respond to fewer treatments, some to more. The protocol that was used calls for 36 treatments, which is what insurance companies will frequently authorize. Sometimes there's a bit of variation. How much time needs to pass? Again, protocol, it's 5 days a week, Monday through Friday for 6 weeks, plus the tapering treatment, 6 tapering treatments after that. What we know from experience is that multiple times a day can be tolerated. The protocol that we have was developed because we didn't know all these things now. And as George told me one time a few years ago, that if he had known that it was going to get kind of ironclad about it. He might have come up with something else, but there was so much unknown then. So we have this protocol that we're, in a sense, wedded to, but we know from some studies at Emory University that 5 days work, 5 days, 5 times a day works. We know from the VA study, 3 times a day can be effective. And in our own experience, there are people that have traveled here and will do multiple treatments a day because of their system. Insurance won't deal with that. So the only way to do that is to do it outside of that. In terms of the training, in terms of doing the motor threshold and prescribing it, it's my opinion, need to have a psychiatrist that's familiar with treating depression. And in terms of the actual person in the room, each manufacturer has its own training requirements, which are learning how to use the system, how to assess for side effects, and so forth. So there's a training system with that. We have within our system some people who are trained in that manner, and we also have some nurses who are also trained in that manner. But it could be any mental health clinician or individual who's adequately trained. There's in the Clinical TMS Society, there's a standards committee, and as part of that discussion, it's a matter of having the training to appropriately manage the TMS system that's the most important, not necessarily the type of clinical professional training. Any issues with long-term memory loss? Good question, and particularly in light of it was known there would be some connection with ECT, and we all knew that that had memory loss associated with it. So there were a lot of initially neuropsychological testing done, and there's no long-term memory loss. As a matter of fact, it's one of the things that's also being looked at is helping with dementia. And it does seem to have some, in the research I've seen, some positive effect with acute memory, and it has no adverse long-term memory loss. You do the treatment course again, 30 treatments over 6 weeks, and then 6 tapering treatments. What facilities have it in Memphis? Best thing to do is Google, because I don't know for sure. I know it is available in Memphis, but I don't know specifically. Is it the same as the Beamer device from Germany? No, that I've not ever heard of that, so I'm not familiar with that. What about TennCare and Medicare? I talked about TennCare earlier. Medicare, it was one of the actual earlier coverage providers, and so it is a Medicare covered. They currently in Tennessee, Medicare requires 4 antidepressants and a course of psychotherapy and severe depression. There are 7 jurisdictions for Medicare. 3 of them now require only 1 antidepressant. Is a referral needed? No, it is not needed. Any chance of strokes due to the treatment? No, there's no evidence of strokes occurring. It's used to treat the depression associated with strokes, and also in some research context, the difficulty with speech associated with strokes, because it's increasing the plasticity of the brain and enhancing the brain recovery. It's a question about ADD or ADHD, and there is no evidence that it benefits ADD or ADHD. There are other neuromodulation techniques available for that, but TMS does not appear to be one of those. Question, would it help university students study better? I'm not suggesting it for that. I will say there have been 2 studies that have been done, one with Harvard undergraduates at Beth Israel Hospital and one at Northwestern University Medical Center for Northwestern students. They had TMS done for quote unquote normal college students. The outcome of that was they saw short-term improvements in memory. So I don't think it's something that's going to be necessarily a good study aid, but what we know is that it doesn't adversely affect memory or concentration. Options for patients without insurance or insurance has denied. We're limited in that arena. Sometimes there are some, we've been able to work with some patients to find some ways to accomplish getting TMS even when there are difficulties with that. The insurance, but typically we don't have too many insurance denials when people meet the criteria. Are there still any clinical trials being done? There are. I mentioned the ones for the bipolar depression and PTSD. There are ongoing trials. The best way to find something is look up clinicaltrials.gov, and you can type in TMS, and that can be something that you can find trials being done there. One question, are neurobiology students able to do a research internship in this field? And if so, do you know where? There probably are opportunities for those types of things. Last summer, we had an intern who was a college student, and they just learned about TMS and were trained in it. So that it's something I'd encourage people to check with local places that have it and see if there's an opportunity. I don't know of anything organized in that, but some places do more research. South Carolina does more research in it than many places. Harvard does, Johns Hopkins does. And some of on the West Coast, UCLA, Ian Cook out there has done research in the past. So there are ways to look, and you can contact them and see. Closest to Jackson, Tennessee, there used to be a place in Jackson that was doing it at Pathways, I think was the name of it. But I don't know if they're still involved or not. Another question, is TMS the total focus of the practice? I do have a psychiatric practice, and then we have 2 TMS clinics, one in Green Hills part of Nashville, one in the Cool Springs part. But I do see patients otherwise also. What would I suggest for patients unwilling to take antidepressants so they would not qualify yet would want to try TMS? I think that's everybody's got to kind of think of this on their own, what their own needs are. And if you just don't want to take antidepressants, one of the things somebody can do if they have insurance is they can go to their insurance company and tell them that they don't want to take medications and see how the insurance company responds. Will it help with fetal alcohol syndrome? No evidence of that, but if someone has fetal alcohol syndrome and they end up being depressed, it would be something to consider. There are no real adverse effects of treating depression with other things. Question about do we determine improvement mostly self-reports by patients? That is a part of it. When we do research, we do some other clinician-rated scales as well as the patient-related scales. There is no way of looking at it without using somebody making a judgment. And the most profound things, I think, are the patient scales, because that takes the clinician out of it. But there's not another way to try it, to classify the improvement other than some type of subjective response. Would you suggest the possibility for someone with agoraphobia? If somebody has agoraphobia and they're depressed, treating the depression is probably going to help with agoraphobic symptoms. There's not any evidence of it specifically treating agoraphobia. Are there European locations? Yes, we're part of the NeuroCare group, which has 13 locations around the globe: Australia, Europe, and United States. And there are a number of the NeuroCare locations in Germany and Europe and Italy now. If there are any other questions, I'll be glad to try to respond, give people another minute or so to put that in. And just give again, kudos to the Tennessee Suicide Prevention Network. It is important work, not recognized as much as it should. And I just want to thank you for the work that you do, all of you on the front line that are treating patients and trying to help patients and their families function better. If there are other questions that come up, be in touch with us at Nashville NeuroCare Therapy. We'd like to get the news out about TMS, and we found it to be a very powerful way to help people live their life better and for their families as well. Thank you very much.